Okay, welcome back, everyone. And as you can see, we're running a little bit behind just because of earlier technical difficulties. We hope to catch up on that. So thank you for returning. I want to thank Meredith Clement and the wonderful panel we had just before on continuum of care. And we have another exciting, wonderful panel coming up right now on implementation science, which is one of our new tracks at this conference. And I'm going to kick it off by introducing the two moderators of the session. We have Elvin Geng and Professor Saiqa Mullick. Dr. Elvin Geng is a tenured professor in medicine at the Department of Medicine at Washington University in St. Louis. He's also the director for the Center for Dissemination and Implementation, Institute for Public Health, also at WashU, and director of Dissemination Implementation Research Core in the Clinical and Translational Science Institute at WashU. For over 10 years, Dr. Geng has been deeply engaged in implementation research to better understand and to close gaps in the use of evidence-based interventions for vulnerable populations of individuals living with HIV. And along with him, we have Professor Saiqa Mullick, who is Director of Implementation Science at WITS RHI. She has both a medical degree and a PhD in infectious disease epidemiology from the London School of Hygiene and Tropical Medicine. And for the last 5 years, she served as Deputy Director on the Options Consortium, a USAID-funded project focused on research and access for HIV prevention for women, providing co-leadership and strategic direction for this consortium of 9 international organizations working primarily in South Africa, Kenya, and Zimbabwe. And she currently oversees a large portfolio of projects addressing introduction of innovative approaches and technologies for HIV prevention and sexual and reproductive health with a focus on adolescent girls and young women. As you can see, these are both experts and highly qualified to be moderating this implementation science session. So I turn it over to you, Elvin and Saiqa. Thank you.
Great, thank you so much. And thank you so much for the introductions. Just to say, we have 3 excellent speakers lined up for this session, and we're going to hear about prevention technologies in the pipeline. We're also going to hear about innovative models of HIV prevention and treatment and care in general. And our expert speakers are going to be discussing how we think about the design of effective HIV interventions and innovations. So I'm going to start off by introducing our very first speaker, Ariane van Straten. She's a senior fellow with the Women's Global Health Imperative Program at RTI International, and she's a professor at UCSF. She conducts socio-behavioral and clinical research to develop and evaluate various biomedical HIV prevention and multipurpose prevention technologies. She's also leading the development of a biodegradable implant as an end-user informed long-acting delivery platform. And for the past 25 years, she's accumulated extensive experience with integrating clinical and socio-behavioral research in the design and conduct of biomedical prevention studies globally, with a particular focus on preventing HIV in women. Her talk is entitled Novel Prevention Technologies, Lessons Learned, and a Glance at the Horizon. Unfortunately, her camera has some issues, some technical issues, but Ariane, if you could share your slides, and we're looking forward to hearing from you.
So can you see my slides?
Yes, we can. Thank you.
Thank you very much for the kind introduction. I have trouble moving my slides, so let me make sure I am able to do that. Someone may need to move the slides for me. I am not able to move my slides.
Ariane, can you move them using the arrow keys? Mia's just suggest.
It's not helping.
It sometimes, Ariane, it sometimes helps when you go come out and go back in again.
We could have a we could take the next speaker perhaps, but let's see if this works. Okay,
No, it's not working.
Okay, so maybe we could move on to the next speaker and try and sort out the technical issues in the meantime. Elvin, over to you.
Great. So thanks all for bearing with, and I'm sure we'll have this sorted out shortly. We'll go on to our next speaker, and this is we'll hear from Dr. Julie Dombrowski. Dr. Dombrowski is an associate professor of medicine at the University of Washington and deputy director of public health at the Seattle King County HIV STD program. She's well known for her research on improving HIV and STI clinical and public health services, in particular for vulnerable populations. And she is also continues to provide primary care at the Madison and Max HIV clinics in Seattle. So we're looking forward to hearing from your multifaceted perspectives, and we'll hand it over to you.
Great. Thank you so much for that introduction. It's really my pleasure to be here today to discuss evolution and impact of innovative HIV care models. I will begin today's talk by discussing the concept of differentiated service delivery, and then I will focus on the need for care models specifically tailored for high-need complex patients. And that will be a focus on the United States context. I'll describe low-barrier clinic models and finish up by presenting some implementation research priorities in this area. So this slide presents what is certainly an oversimplified representation of the evolution of HIV service delivery. Initially, clinic models for HIV care were essentially one size fits all. We wanted to make sure that services were available for everyone who needed them, but we didn't necessarily tailor the way we delivered services for individuals with HIV based on their needs. Much of the effort in recent years to increase patient engagement in HIV care and consequently viral suppression has been about supporting individuals to engage in HIV medical care and services. And this includes crucial interventions like the ones shown on this slide and several evidence-based strategies, most of which we need to continue to invest in. But ultimately, these interventions are mostly focused on supporting individuals with HIV to engage in care as it's traditionally organized. The next stage of evolution is changing the way that HIV medical care is delivered. This doesn't need to be for everybody. In fact, one size does fit most, but for especially stable patients who can benefit from streamlined services, and on the other end of the spectrum, very high need patients who don't engage in conventionally organized care, we need something different. And that's the basic idea of differentiated service delivery. This strategy is a client-centered strategy to adapt services to the needs of individual clients and tailor the level of service intensity appropriately. In addition to improving services for patients, an important motivation for differentiated service delivery is to reduce burden on the health system. We don't want to invest scarce resources where they aren't needed. And there are several excellent examples of methods to streamline care for patients who are doing well, including fast-track ART refills, adherence clubs, and task sharing. But until fairly recently, most of the studies of differentiated service delivery were not geared towards changing services for the higher need, less stable patients who were not well engaged in care. And before I describe some examples of approaches to that issue, I'd like to present this figure on the elements of tiered care that I think can be useful for structuring our thinking around innovative care models. As you can see, the person with HIV is in the center. It's a person-centered model, and on the sides are 4 gears that we can change in order to tailor service delivery. These include service intensity, service frequency, service location, and the healthcare workforce delivering the services. A recent example of an innovative care model was studied in the DO-ART study. This was a randomized controlled trial that recruited participants in South Africa and Uganda who were eligible on the basis of not taking ART and being viremic at the time of study entry. The participants were randomized to one of 3 care models: a clinic group, which was the standard of care, a community group in which care was delivered in the community, and a hybrid group which started in the clinic and moved into the community. And as you can see on the graph at the right, viral suppression at 12 months was the primary outcome. And community delivery was, in fact, more effective at reaching viral suppression, or helping patients reach viral suppression, than the clinic, and the hybrid was in between the two, suggesting that for many patients, changing the standard care model surmounted barriers to viral suppression that couldn't be surmounted as well in the context of the clinic. Another example was the SEARCH study, which was a universal test and treat trial in Uganda and Kenya. And in this study, randomization occurred at the community level, and communities either continued standard care or implemented streamlined care, which was a multi-component intervention, including the things you can see listed here. And as you can see on the right, viral suppression at 3 years was compared between individuals in the standard care communities and streamlined care communities, stratified by the individual's ART status and viral suppression at baseline. And where the intervention made the most difference was among patients who were ART experienced and had baseline viremia, so patients with higher needs. And I think what this study shows really nicely, just like the DO-ART study, is that changing our healthcare systems is necessary to reach the next increment of improvement in viral suppression. Lack of viral suppression isn't all about barriers in the lives of individuals with HIV, but also about changing our systems and reducing barriers. So now I'd like to pivot to thinking about the context of this issue in the United States. And from here out, I will use the term high-need complex patients to refer to patients who aren't succeeding in conventional HIV care. Or perhaps I should say conventional HIV care is not succeeding for them. Consistent with the concept of differentiated service delivery, we need to have a tiered service strategy in the US to match the spectrum of support need. The graph on the lower left shows the tremendous success of the Ryan White Care Program, with an increase in viral suppression from about 70% in 2010 to 87% in 2018. This is the highest level ever recorded. It is outstanding. It's cause for celebration. And 13% of patients in the Ryan White Care system still aren't virally suppressed, not to mention those who aren't in the system, and so more needs to be done. The issue of treating high-need complex patients with innovative care models is not unique to HIV. There's a movement to establish a medical specialty of complex care advocated by the National Center for Complex Health and Social Needs. The National Academy of Medicine commissioned a report on effective care for high-need patients, and there are very effective and well-known strategies for engaging high-needs patients, such as the VA Veterans Program, Patient-Aligned Care Team, or PACT, and in mental health, assertive community treatment, as well as the long-standing healthcare for the homeless model. So how do we define the target population of high-need complex individuals with HIV? Well, certainly any definition is likely to be oversimplified, but there are some common features. First, they're virally unsuppressed, or to be more specific, virally unsuppressed when in the community. There are some people who are suppressed when they're in the hospital or incarcerated for a period of time, but don't remain suppressed outside of that context. Number two, they're not engaged in HIV medical care. We certainly have some patients who come to clinic regularly but aren't taking ART, and that's not really the population I'm speaking about here either. And finally, they have complex medical and social needs, which typically include homelessness or unstable housing, substance use disorders, mental health disorders, or any combination of those three. And it's important to note here that deeper structural factors underlie and lead to this situation, including poverty, racism, homophobia, mass incarceration, early childhood trauma. And as we think about how to change our system to meet the needs of the highest need patients, it's important to emphasize that a driving principle and central goal of this should be to mitigate the impact of social and structural factors on HIV outcomes. So now I'd like to turn to some examples of innovative care models for high-need complex patients in the US and describe first what I mean by low-barrier care. This is care that's designed specifically to engage the quote-unquote hardest to reach people with HIV. It changes the model of care available for patients who don't engage in mainstream care. It aims to really reduce or eliminate health systems barriers. And it's informed by low barrier models of substance use disorder treatment and attempts to incorporate those concepts and principles into HIV care delivery. Low barrier clinics are increasingly being implemented in several areas of the United States. And I am sure that the map I'm showing here, which is some of those clinics overlaid on the EHE priority jurisdictions, this map is incomplete. I did a literature search, but most of this comes from my own familiarity with these programs. They usually get implemented as clinical and public health practice programs and not research, and thus they aren't really very well represented in peer-reviewed literature. So if I've left out a clinic that you know of or are working on, I humbly apologize and would love to hear from you after this talk. One of the key features of low barrier care model is that it's adaptable to local needs and resources, but there are some core elements of the model as well as some common elements in most existing clinics. The three that I've bolded at the top are really, I think, the core elements. First, walk-in access to primary care. So this is different from walk-in access to urgent care that almost all HIV clinics have, but really delivering HIV care and primary care on an entirely walk-in basis when the patient needs or wants care. Second is high-intensity case management. This is fairly self-evident, but we do need case management with usually lower patient ratios than we have in standard care. And we need to address immediate needs such as food, clothing, or hygiene in some way. I realize it may not always be realistic or feasible to address all of these, but the more that we can help patients meet their basic needs, the easier it is for them to prioritize a care visit on any given day. So I'd like to focus on three specific clinical examples and talk about impact evaluation of two of these models. The first is the Max Clinic in Seattle, which is operated by the University of Washington and Public Health Seattle-King County. This includes walk-in access to care, financial incentives for coming to care and getting virally suppressed, and cross-sector collaboration, most importantly with the jail. The second is the pop-up clinic in San Francisco, operated by UCSF, and this clinic is specifically designed for people who are homeless or unstably housed. And the third is the Circle Clinic in Jackson, Mississippi, which is operated by the University of Mississippi. And that one is just getting started, but it's a really exciting project and demonstrates that low barrier care models can be operated in geographically diverse areas with distinct contexts. So to evaluate the impact of the Max Clinic, our group conducted a retrospective case control study. The cases were the first 50 patients enrolled in Max Clinic. The controls were 100 matched patients who would have been eligible for Max Clinic but remained enrolled in the main clinic. And what we saw among the first 50 patients enrolled in the clinic is that 20% had at least one suppressed viral load in the year prior to enrollment. They were all virally suppressed, however, at the time of enrollment. And in the year after, that increased to 82% who had at least one suppressed viral load. Among control patients, shown on the blue line here, we also observed an improvement from 51% to 65% in the year after. So although both groups of patients improved, the Max Clinic patients were more than threefold as likely to achieve viral suppression. We also examined engagement in care in a similar way, and you can see that both groups of patients improved from the pre to post year. And although there was a single signal of increased engagement or difference, it wasn't statistically different between the two. However, we used the traditional definition of medical provider visits for engagement, which is not really the most useful engagement measure for this model, when most of the visits are with case management personnel. We also conducted some qualitative research to better understand patients' views of the clinic and which components they thought were the most essential. The key theme that came up when patients were asked open-ended questions about the Max Clinic was that they appreciated how the clinic made them feel and how they were treated and how their social circumstances were recognized and addressed. There was a very strong feeling that walk-in access to care was essential, not just for the convenience of it and able to fit into a life that can be somewhat chaotic, but also because it alleviated the shame that some patients felt from missing appointments in their prior HIV care setting. For incentives, there was really a heterogeneity of opinion, with some people finding them essential and others not important at all, but a general theme that the incentives can be a bridge to engagement, but aren't the solution in and of themselves. Switching now to the pop-up clinic, I don't have results to share, but do understand that an impact evaluation is underway and the results will be presented soon. Here, the team decided to use a prospective cohort study approach where patients who were eligible for the clinic were enrolled and followed, and uptake is examined as well. So the outcomes for this include uptake, incidence of ART initiation, return to care, and viral suppression at 6 months. The research team associated with a pop-up clinic did a fascinating study using a discrete choice experiment to understand which elements of the clinic or low barrier care approach would be most important for their patients. And they enrolled 65 participants who would be eligible for the clinic in the study and asked them to choose between hypothetical clinics, which varied on 5 different dimensions shown here. And what stood out was that without a doubt, the 2 key things were the care team getting to know me as a person and drop-in visits with a willingness to trade them out in gift cards shown below each of these. So my interpretation, together with qualitative interviews in the MAX clinic, suggests that the key things in low barrier care are really how patients feel they're treated by the care team and walk-in access to care or drop-in visits really being essential. So finally here, I've listed what I think are implementation research priorities related specifically to low barrier care clinics, but also other innovative HIV care delivery systems. Impact evaluation is something we still don't know enough about. Many of the clinics in the United States, as I mentioned, are not implemented in the research context and don't necessarily have set aside funding for impact evaluation. But I think that we can be creative and ideally do controlled evaluations and consider quasi-experimental approaches when randomization isn't feasible or appropriate. In addition to examining HIV care continuum outcomes, we also need to focus on the impact of these models on other chronic conditions, as well as health service utilization. I don't think we understand yet enough who needs and benefits most from low barrier care approaches, which are very high intensity. How do we effectively and appropriately and most cost effectively identify patients to transition in and, if possible, out of low barrier care? And finally, economic analyses are dearly needed in this area. The DO-ART study, which I showed earlier, did have an economic analysis with a co-primary outcome. And it's important, I think, for us to do more of these. So finally here, I'd like to acknowledge the people who helped me putting this talk together and Drs. Geng and Mullick who are moderating this session. I look forward to the discussion and thank you very much.
Oops, sorry. Thanks. I think we'll take 1 or 2 clarifying questions and then we'll save discussion towards the end. And we'll make it quick. So I guess going once, going twice, I don't see any questions coming through. So maybe we will head on to the next and I'll hand it over to Saiqa to introduce the next speaker.
Great. Thank you. Thanks. Great. So we're going to move on to Delivette Castor. She's an assistant professor at Columbia University, Vagelos College of Physicians and Surgeons, and director of the section on health equity and implementation and dissemination science within the Division of Infectious Diseases. And she currently conducts HIV prevention research and implementation research with a focus on health equity, women, and adolescent health. And prior to joining the faculty at Columbia University, she worked at USAID and the State Department in various capacities within the PEPFAR program, and I've worked with her for many years. And the title of her talk is Treatment as Prevention 2020, Rethinking Strategies and Tactics for Implementation. Thanks, Delivette. Over to you. Deli, you're muted.
Of course. Thank you. Thank you, Saiqa, and thank you to the organizers for putting this session together, and to you and Elvin for the really good feedback that you gave in preparation of the talk. Can you see my slides? Sorry.
Yes, we can.
Okay. As Saiqa mentioned, the title of my talk today is Treatment as Prevention, Rethinking Strategies and Tactics for Implementation. For today, I'll start with just a brief coverage of treatment as prevention and highlight some of the innovations in implementation going forward. And we'll focus mostly on the global health side of things, but we'll use some examples from even some of our domestic work. So the schema that I have here first really starts to just give a highlight of a few of the key studies in this space. This is by no means exhaustive, So apologies if I've left any key people out, but I really wanted to just kind of focus in on particularly some of the big studies that have set the stage and informed some of the work that's happening, particularly in sub-Saharan Africa and places where PEPFAR tends to focus. So the concept that treatment can also prevent onward transmission was really heightened in the early 2000s and came from observation of both ecologic and observational studies, like the work from Julio Montañez's group in British Columbia that really started to illustrate that there was a lower incidence of HIV in settings as treatment coverage increased. Then in 2009, there was a very provocative modeling study done by Ruben Granich and colleagues using data from South Africa that really started to provoke the idea of treatment as prevention from a population level standpoint. In this model, what they put forward was really universal test and treat with implementation at scale and annual HIV testing, and modeled this concept and showed that it actually could reduce HIV incidence to less than 0.1%. Around the same time was also a clinical trial that was ongoing that demonstrated the clinical efficacy of treatment as prevention and showed 93% efficacy. These things together really set the stage for several large population level trials that were conducted mostly entirely in sub-Saharan Africa. And the four that I will feature are the ANRS 12249 study, the POPART study, the SEARCH study, and the Botswana combination prevention study. The last three were largely funded by PEPFAR, but also included other funding mechanisms. And what these studies really showed, as you can see from the hazard ratios, is that, for instance, some showed that there was a population level impact of treatment as prevention, and others did not. The POPART study showed in one of their arms, this was a 3-arm cluster randomized trial design, that we saw about a 30% reduction in HIV incidence. And similarly, in the Botswana study, we saw almost about the same effect size in that cluster randomized design. While the SEARCH study did not show significant reduction in cumulative incidence, there was certainly reduction in the incidence rates. And so here we have a summary of the trials looking at the 390s across the studies before and after the intervention was initiated. And in each instance, you can see that with the first 90, there was certainly good uptake of HIV testing. Similarly, getting people on ART, there was good coverage. When we look at the third 90 with viral suppression, this is where it looks less striking across all of the studies. But again, the cumulative effects were different. And then this is work from Diane Havler. We're here, she's showing that on the right-hand side of the slide, we see that HIV viral suppression, when we look at the proportions suppressed within the treatment studies as opposed to what's happening in that national setting, we see very striking differences. So although the studies had mixed effects at the population level, I think all of these together, in addition with the clinical studies, really informed the continuation of achieving 90-90-90 and now 95-95-95. And the intent is that by the end of this year, most countries, most low and middle income countries would actually have a test and start policy and will be in various stages of implementing implementing this. So these studies were really a massive enterprise to really get to scale. And they had some central elements in common when we think about the intervention for treatment as prevention. They all had universal testing, mostly in the form of annual home-based testing. In the case of the ANRS study, which was a bit earlier, it was also testing at 6 months. They also all had enhanced linkage to care and universal treatment at various thresholds. So So for instance, with the Botswana study, there was an additional inclusion of even viremia for treatment. Because of the complexity of the studies, they all also used mathematical modeling, both to examine what the impact would be and immediate within the context of the study, and in order to project forward. So where does these studies actually leave us is the question. Where do we go from here? Because again, as I mentioned, these were fairly massive enterprises. They were done in a uniform way, and it isn't, and in many low and middle income country settings, that level of effort may not be replicable. So this is another modeling exercise that was also useful, done by Sarah Jane Anderson, which highlights the notion that a focused approach that includes tailored interventions for local epidemics can actually result in even greater reduction of incidence, and also illustrate that there may be cost savings with a more targeted strategies. So this is where we are in thinking about implementation for 95, 95, 95, and where can there be additional efficiencies in achieving those. This is a slide utilized from WHO that I'm sure many people are familiar with, that shows globally where we are in terms of reaching the UN/AIDS fast track goals. And as we can see, among all people living with HIV, about 81% are estimated to now know their status, 67% are on treatment, and 59% are virally suppressed. There's been a host of different evidence to further inform the delivery strategies for testing, linkage, ARV adherence, and then less information on really the delivery support and then evaluations of those deliveries. So the rest of my talk will start to look at, among this wide range of strategies, which ones can help inform more efficiencies for scaling up and reaching the last end of this spectrum. So here we have an example of testing, and there are a number of different testing strategies within testing. For certainly at the facility level, there continues to be innovations in testing, but really as we think about how do we get to this last group to really reach the UN/AIDS fast track goals and to achieve treatment as prevention, thinking about strategies that are really community-based testing strategies like self-testing, index testing, and social network testing. So what I have on the left-hand side here is an example from the Linkages program, which was a USAID-funded program and operates primarily in the PEPFAR context, where they implemented a strategy for using a peer network testing to examine its ability to identify undiagnosed people. And these were done in two key populations among female sex workers and MSM in 3 different country settings. And as we see from this strategy, it was able to identify in Burundi significantly higher proportion of female sex workers with HIV, similarly in Côte d'Ivoire, and a marginal effect in the DRC. Also for men who have sex with men, this strategy was also able to identify more men who have sex with men as new diagnoses in both Côte d'Ivoire and DRC. Another key linchpin within strategies for improving treatment as prevention is the issues around linkages. And linkage to care is often oversimplified. We really think that it's portrayed as just a referral step after someone is diagnosed HIV positive, and not really taking into consideration all of the specific processes that goes into play to ensure that an individual is successfully linked, and that if they linked, they remain linked to the system. So here we have an example which is actually domestic from our work at Columbia University, where we identified patients within the network system who are HIV positive, but may not necessarily be linked to care. And this is used to develop a dashboard in Tableau that then flags the individuals who may need additional outreach because they have not been seen and have not had care based on the university system. And the first year of this implementation, we were able to identify about 31% of people who were previously out of care, and a high proportion of those who are also virally suppressed. This strategy is also being done in a similar fashion in Nepal. Also, again, this is a slide utilizing data from the Linkages program, where they use the DHIS system, also using key identifiers and an algorithm to identify those individuals who may be lost to follow-up and then and targeted for linkage back into care. As more and more systems move into electronic health records, particularly in low and middle income countries settings, and we improve in our ability to use data science to develop phenotypes of these patients, this strategy can also prove to be effective and efficient. The other factor in thinking about linkage to care, again, is that it's not just the initial linkage, but remaining linked to care. And sometimes people leave because they were not satisfied with the care that they received. So in this USAID-funded program through Linkages, they've now implemented a smart system that allows for patient feedback. And so after the service, the patient, like would be done in many other sectors, can provide information about the level of care, the quality of care, their satisfaction, and how they would rate it. And this is used in a quality improvement strategy and is also utilized for supportive supervision at the site level and at the program level. Further details can be found here. So the other aspect of ensuring that treatment as prevention is successful is also even thinking about actually the elements within treatment itself. The regimen, in order to scale this up, cost, again, is a fairly significant factor. And also in many low and middle income countries, the frequency at which drug is dispensed to clients and models that involve community art delivery. Here I'm illustrating from the supply chain perspective, as many countries are moving to a multi-month dispensing approach and ensuring that there's sustainability and response in the drug supply chain. This is a dashboard that was developed by USAID Supply Chain, where it tracks, again, the delivery strategy and ensures that there aren't stockouts at the national and regional level. This slide from WHO highlights the strategy where we are in terms of the rollout of treatment as prevention across the cascade. So currently, 95% of low and middle income countries, 96% have actually adopted a treat all policy. Dolutegravir, which has resulted in significant cost savings as a first-line drug therapy, is being rolled out now in 78% of countries. And routine viral load monitoring is currently practiced in 72% of countries. A very important part also in the implementation strategy is also the monitoring. And these are now being implemented at both the national and global level. Inclusion of indicators that really starts to track how treatment as prevention is occurring. That includes both policies and implementations, such as the number of sites that are implementing it, where it's being implemented at the regional level, and whether or not it's piloted. So where else do we go to inform implementation? From an intervention standpoint, there really needs to be the capacity for implementing processes in a nimble way that is evidence-informed and really creating real-time adaptation for treatment as prevention. It's also become really clear that the policy environment needs to also be there, that really takes an approach at reducing system-level issues such as harm reduction and influences on migrant populations or other populations that may be marginalized and or stigmatized. Also, influencers at different levels in the system who are highly motivated and take an approach that is a social justice-oriented approach is also critical. And government investment is also critical. That's from a policy standpoint and a financing of implementation standpoint. So as we think about this very last phase of implementation, I shouldn't say last phase, but what it would take to really get treatment as prevention fully to scale, and thinking about who remains left behind in this strategy, we really start to think about other social determinants that may influence who accesses services, why they access services, and where they access services, and what might be some of the barriers, such as environmental or economic factors that may influence access to services. So these would be, again, improvements in inclusion and agency, communication messaging around dissemination to all populations, as well as delivery points that are truly stigma-free and expanded beyond just the healthcare setting, and economic stability. On the right-hand side, this is actually also another example coming from one of the large clinical trials that sort of modeled what might be some of the factors that influence. This is particularly from the SEARCH study that was examining what might be some of the factors that influence observed effects, and started to think around issues of migration in many low and middle income countries as people move from one setting to the next, ensuring that there are services at border points for delivery of treatment, in addition to strategies like multi-month scripting, can help to resolve some of these issues around migration. And the last, I would say, in terms of really thinking about who we are leaving behind as we continue to scale up, and what strategies can improve efficiencies, we think about issues around, first, within the health system, are we including sufficient metrics to be able to capture those individuals, such as migrant status, key populations where it's appropriate and can be identified, but keep the individuals protected, would be also critical as demographic markers of ID risk and ongoing service needs. Also, even in the mathematical models, also thinking about where we can include these markers so that models can be more precise and more focused, as we understand that targeted strategies for population-specific needs are improved. And again, with the community strategies to really expand access at the points where people would need services. So I'll wrap with, again, thank you for the opportunity to talk through this from the global health standpoint. I have no conflicts of interest. And the slides were really content contributing from within our group here at Columbia University, and with colleagues within supply chain at USAID Washington, and also with programs funded that are delivering some of these new strategies in a public health setting and continue to be evaluated. Thank you.
Thank you so much, Delivette. That was an excellent overview. Are there any questions for clarification? If not, we'll move rapidly to Ariane's presentation. Ariane, over to you.
Can you see my slides now? And apologies for the technical difficulty. So as Saiqa kindly introduced, I will focus my talk on novel prevention technologies, lessons learned, and a glance at the horizon. This is my agenda. I'll look at the expanding toolbox. I'll present some technologies by product pipeline stages, the discovery, development, and delivery stage. I'll talk a little bit about what is at the horizon, have some concluding remark, and along the way, I will highlight lessons learned with a pink star. So this is the expanding toolbox of biomedical prevention technology. What you can see is that a number of these technologies are providing more options for end user. In green, you see long-acting technology. I included the pill because, as you will see, there is development of a long-acting pill. You can also start to choose about and have topical products in pink. There are methods that are for the vaginal compartment only, and some that are on demand. Currently, only the pill is approved as oral PrEP, but other technology like the injection and the vaginal ring are rapidly moving towards approval, and we expect to have some of them approved by next year. Like we've seen in the contraceptive era and field, more choice produce better outcome. And for contraception, increased choice of contraceptive was associated with increased contraceptive uptake, better health outcome, and this comes from a WHO systematic review, as well as more persistence with the chosen method that women were able to choose. And what we realize also is that contraceptive needs and choice do vary over a reproductive lifetime for women, and we can anticipate the same for PrEP. So next, I'm going to talk about some of these novel technology by the product pipeline stages. This is adapted from a slide from my colleague Betsy Tolley at FHI 360, starting with the discovery stage, from the ideation all the way to preclinical, the development stage, which are pretty much the clinical trial stages, the delivery stage, which include open label and bridging study all the way to patient care, and then I'll briefly mention some technologies at the horizon. So in the discovery stage, I will talk about an implant we are developing, which is a biodegradable implant. The first lesson I'd like to share with you is that sometimes it's difficult to know which way to go. And as early as the discovery stage, it's important to engage end user. So the lesson is it's never too early to engage them in your research about product. And I'll show some example. So this is a slide that summarizes some of the work we've done on our HIV PrEP implant, as well as an MPT implant that would address both HIV prevention and contraception. We are developing a biodegradable implant that provides sustained release of drug over months to a year. It is compatible with commercially available trocar. And some of the milestones that we have achieved, in large part thanks to USAID funding, is more than 1 year drug release in vitro, over 6 months of release in animals, vaginal efficacy in non-human primate, and co-release of hormone and ARV in a small animal models. Other implants are also being developed by other groups, primarily non-biodegradable. A TAF implant is being evaluated in South Africa. It has been developed by Oakcrest. An islatravir implant that I'll talk a little bit about later is being evaluated by Merck. And the SLAP HIV at Northwestern University is developing a cabotegravir implant. As far as our work is concerned, along with the R&D, we have also focused on preferred user characteristics and really gotten input primarily from young cis women in sub-Saharan Africa, but also from male partners, healthcare providers, and men who have sex with women, men who have sex with men in sub-Saharan Africa and now in the United States, about their preferred attributes. The methods that we have used to do this are, in-depth interviews, focus group discussion, discrete choice experiment, and questionnaire surveys. This is a slide that is summarizing some of the insights that we've generated from engaging end user very early in the development process. So you see on the top part of the slide, the change in our implant from generation 1 to generation 4. And I will just highlight a couple of improvements that we did thanks to our end user input. First of all, we understood that duration was a key attribute for an implant and that anything less than 6 months wouldn't be of interest. We also realized that the aspect of the implant was important, and we improved its look. We were recommended to use existing trocar for insertion, so we made sure our implant was compatible with existing contraceptive trocar. And we again got feedback that duration was more important than number of rods. And so this is allowing for an expansion in our opportunity for a longer duration implant over a year, but because we can consider using more than one rod in end users. Now I would like to move to the development stage, and I'll talk about multipurpose prevention technology and long-acting injectables that are at the clinical stage. So this is an example of a study where we enrolled heterosexual couples in Zimbabwe and Uganda to try to understand both the male and the female partner perspective on key attributes of MPTs that would drive their preference. We focused on 4 delivery forms: the ring, the film, the insert, and the oral tablet. And each partner completed a discrete choice experiment, as well as completed a joint discrete choice experiment, so we understand better the relationship dynamic of partners in deciding which attributes are important. This study is ongoing, and we expect to have findings available to disseminate next year. About products, the multipurpose prevention technology rings are also in the clinical stage. These are examples of 3 different rings. The top one is developed by IPM, and it's an extended release 3-month ring, which delivers both LNG and Dapivirine for contraception and HIV prevention, and it was recently evaluated in a phase 1 trial among 24 US women. Conrad is developing a tenofovir levogenesterol ring for HSV2 and HIV prevention, as well as contraception. And then the Oakcrest Institute of Science is developing a pod ring, which was evaluated in the preclinical stage in non-human primate. And it also is targeting HIV, HSV2, as well as a contraceptive. So multipurpose prevention technology are really an important sort of technological advance for women, because women need better protection both from unintended pregnancy as well as from HIV and STI. So lessons number 2 is that when you can, you should bundle your indication. All data from the field indicate that the majority of women would prefer to have combined indication rather than separate products for the indication they need to be using. Moving now to cabotegravir LA. So cabotegravir is an integrase inhibitor that has been developed by ViiV as a long-acting injectable. HPTN has been testing and evaluating cabotegravir LA. Here it was in a phase 2 trial, and Betsy Tolley from FHI published these data showing that, generally speaking, this bi-monthly injection was very well accepted among men and women who were participating in the trial. The only concern was the pain at the insertion site. Moving on to a landmark result that was disseminated this spring was the result of the HPTN 083 trial. This was a large phase 3 trial in MSM and transgender women, which demonstrated high efficacy of cabotegravir LA compared to oral daily Truvada. The trial was stopped early for efficacy and is moving into an open label extension with choice. And a sister study called HPTN 084 is currently ongoing, and we are eagerly awaiting the result of that trial as well. Lessons learned from this particular trial is that lowering user burden by providing a long-acting prevention method does improve product effectiveness and protection. Now, finally, at the delivery stage, I will focus on vaginal ring and pill use in a particularly important population, which are adolescent girls and young women. So first, I will talk about the MTN 034 trial, or REACH, which is ongoing, and it's a crossover open label phase 2 trial, where adolescent girls and young women that are enrolled in 3 different countries at 4 sites are offered to use for 6 months either method, a daily oral tablet or the vaginal ring. Then they can choose which one they prefer and use their preferred product for another 6 months. So building in choice into our study design. In addition to product choice, young women are also offered a menu of adherence support strategies, and they can choose which adherence support strategy they prefer, and they can also change their mind. They are also given drug level feedback based on their product use, which with a structured counseling. And what we have learned so far, although the trial is still ongoing, is that providing choice is tremendously empowering and increase users' autonomy. So it is important in and of itself beyond an adherence outcome. I will talk now about another study that has been conducted at DTHF in Cape Town to try to increase adherence to PrEP among adolescents, girls, and young women. This has been recently published by Connie Kellum, and it was an intervention where we assessed whether providing a modest incentive based on high level of tenofovir diphosphate in dry blood spot would incentivize girls to use their daily oral PrEP better. The incentivization happened during the first 3 months, and you can see on the graph on the right that in the incentive arm, there was slightly higher adherence than in the standard arm, although it didn't reach statistical significance. However, unfortunately, after the incentivization stopped and over time, persistence dropped very much, like we have seen with other PrEP implementation studies. So the lessons here is that incentive can be helpful, but you also need to lower other barriers to use. So from the 5 different examples I've shown, this is the summary of our lessons learned. And then I will move onto what is going on now at the horizon. And first of all, I would like to talk about an exciting development at the regulatory horizon with the Dapivirine vaginal ring. It received a positive opinion from the European Medicines Agency this summer in July. And so it's moving forward towards regulatory approval in African country as well as through the FDA in the US. Another important development that we've seen with other PrEP technology is that at the time of the pivotal trials, as you can see with the green arrow, the level of estimated effectiveness for the ring was quite modest, around 30%, but with reanalysis of highly adherent participant and user who use the ring continuously and in open label extension, the estimated effectiveness of the ring is over 65% and in some cases may reach up as high as 90%. So an exciting new technology that will be reaching people hopefully very soon. At the clinical horizon, I want to briefly talk about a new exciting drug, islatravir, developed by Merck. It was previously called EFDA. It's an NRTTI, highly potent, and it is being formulated in multiple dosage and indication beyond treatment. So on the left, it's you can see that there's very promising opportunity for islatravir as a weekly PEP treatment, so post-exposure prophylaxis. In terms of pre-exposure prophylaxis, a weekly pill or eventually a monthly pill are being evaluated. And then for even longer duration, Merck is developing a non-biodegradable islatravir implant, which is currently in clinical evaluation. Finally, I would like to mention the AIM study and the antibody-mediated prevention led by HVTN and HPTN, where currently a broad neutralizing antibody called VRC01 is being evaluated as an HIV prevention strategy by bi-monthly infusion of the antibody. This is not meant to be a product, but a new generation of bNAbs that are longer lasting and more potent are also being evaluated and could be then administered either subcutaneously or through intramuscular injection. And that could be also a different way of preventing HIV in at-risk population. So to conclude, more options should lead to better choice, but that also requires to develop the science of informed choice. When we look back at our toolkit with different options becoming available, different indication, different dosage form, it is clear that for each individual, you need to find the right technology at the right time for your right needs and circumstances. So in order to deliver the promise of higher impact, we have to remember that technology do not function in a vacuum, and we need to think about how we can support the integration of these technology from the individual to the public policy level. Some ideas that would need to be considered as we are expanding this science of informed choice is the development of decision tools that include values and preference at the individual level, couple counseling, engagement, and education, education and training of healthcare providers that are often the gatekeeper for these new technology, advocacy, communication, and education at the community level, and then improving access through ease of delivery and lowering cost so that any user can access them. I want to thank you for listening to me, acknowledging our funders and the different studies I've spoken about. And back to you, Elvin and Saiqa.
Great. Thanks. That was a phenomenal presentation and followed a string of really nice discussions. Just to open this up briefly, I think we're going to move forward quickly here because we're trying to catch up a little bit on time. Any questions from the audience for any of the speakers? Looks like none forthcoming at the moment. Maybe before I wrap up, it looks like Saiqa has a question. We'll take the moderator's prerogative to put that out there. So
thank you. Thanks very much. Just a quick question and maybe to Julie and Delivette. You know, we're in the middle of a COVID pandemic, and we've seen that a lot of the, you know, the programs have suffered. And I'm just wondering, you know, from your perspective, what do you see as some of the opportunities or the silver lining that COVID has perhaps presented? Thank you.
Sure. So from the standpoint of our low barrier clinic, it's been extremely difficult. And I know that's not what you asked about, the silver lining, because we've had demand for services and reduced staff effort being diverted. But I think some silver linings are that COVID broke through some bureaucratic barriers, like the need for in-person signatures to confirm Ryan-White eligibility, confirmed in-person face-to-face visits to start Suboxone. That's now allowed with phone visits. And catalyzed, at least for us here locally, some new housing resources that really hadn't been available. So I think those are some silver linings important to think about. Thank you.
Thank you, Saiqa. I would say following what's been happening on the global health side, it has been also, I think, catalytic in some of the policies that are in place, but really thinking about how to implement them better, like multi-month dispensing, where there was still hesitation on how much farther can you take it. And so again, it's made that efficient. I think it also has presented the opportunity to really start thinking about how we can use other technologies. So mHealth has also been done, but really thinking about how do we use mHealth even more in low and middle income country settings. And then thinking about first acknowledging that there is a digital divide, even in low and middle income countries, and then has forced us to think, how do we overcome that and use what's in place? So I think, again, these are some of the, if COVID bore any fruits, it's along the same lines of, what's happened in the US in terms of really pushing forward things that maybe were stuck at the implementation level, but there was policy in place, and so it just needed to move, and so that happened, and just allowed the system. And I think now everyone's thinking about efficiencies because we have to.
Great. So I think let's take one question from the audience, just because I feel like, given this great series of talks, we should make a little bit use of that opportunity for dialogue, even though we're pressed for time. So Jessica Haber asks, I feel like implementation science is moving forward well in research. I'm wondering if the speakers could talk about how well health departments and or ministries are engaging with outcomes in this field and making the corresponding policy changes. Maybe I'll open it up and let our speakers, who wants to take that one? Julie.
I'll let Julie go first.
That's a great question, Jessica. Thank you for asking that. I think someone made the point, and I'm sorry, I'm forgetting which of the other two speakers it was, about how it's never too early to engage end users. And I think the same thing happens here, that at least for health departments, the implementation research really needs to be answering questions that are crucial to the health departments. And I guess I would just make that statement, that if we can start early and direct the research at key programmatic priorities, I think that is a big part of the solution.
Great, thanks.
And I'll just add to that, that's sort of how, in my prior life at USAID, that was our starting point. Our starting point was always, what's the programmatic gap, and where are the ministries involved, and also recognize and acknowledge the gap. And from that, we built the scientific question, but it always started with a policy issue and a programmatic issue that implicitly involved the ministries of health.
Great. Thanks. I think we are short on time, so are going to need to wrap up. I want to thank all the speakers and my co-chair here. Looks like Ariane wants to add a comment. Let's make a little bit of space for that. Go ahead, please.
Oh, sorry. It's complicated with the virtual distance, but yeah, what I did want to say, thanks, Julie, for bringing that comment back into the discussion, that it's never too early to include end users in our research with product development. But perhaps one other thought is that, like when we design research, we should always have a statistician with us to make sure we think forward about how we will analyze our data. We should always have an implementation scientist, so we look beyond the research question of at hand, but we think about how would we implement this should this research be successful, and have that vision, the two-step vision, not just the one-step vision for our work. Thanks.
Great. All right. Well, I think we will wrap it up. I just want to say thanks again for all the speakers. I mean, I do think that one thread that really came through here was this sort of evolving thinking about tailoring personalization, choice in the setting of public health. And I think those two things traditionally have been sort of like held up as one or the other. But I think through some of this innovative scientific thinking, we're really beginning to see that they're two sides of the same coin, and that perhaps these things can drive us towards both more efficient and effective public health. And thinking about the environments to do this science embedded with implementation will be sort of an exciting direction to take these. So let's, I think, wrap this up. Again, thank you all, and thanks everyone for joining the virtual session, which is our new norm, at least for the moment. And I believe we are going to take a break, and we'll come back for the next session. We'll continue. So thanks, everybody.